Hi everyone. This masterclass is about a topic that every ophthalmologist encounters almost daily, yet one that continues to be misunderstood. That is dry eye disease. In this masterclass, we'll be discussing on how our understanding of dry eye has evolved and how we can approach dry eye in our day-to-day clinical practice. So here we can appreciate four pictures, slit lamp pictures with surface staining. Are all these are dry eye? The answer is no. So one of the common mistakes we make is equating the surface staining with dry eye. This complexity is exactly why the definition of dry eye has evolved dramatically over the last 2 decades. This journey can be understood through three major milestones: Deuce 1 in 2007, Deuce 2 in 2017, and most recently, Deuce 3 in 2025. Deuce 1 was the first major global effort to standardize our understanding of dry eye disease. The focus was largely on the tears and ocular surface damage. Then comes Deuce 2. Deuce 2 introduced a revolutionary concept, that is the loss of tear film homeostasis, and this was a major conceptual shift. Dry eye now was no longer viewed simply as tear deficiency. Instead, it becomes a dynamic disease involving tear instability, hyperosmolality, inflammation, surface damage, and neurosensory dysfunction. Now comes the Deuce 3. Deuce 3, Deuce 3, the most important message being symptoms are central. A patient must have symptoms to diagnose dry eye disease. Signs alone do not constitute dry eye. Thus, dry eye is defined as a multifactorial symptomatic disease characterized by loss of homeostasis of the tear film or ocular surface, in which tear film instability and hyperosmolality and ocular surface inflammation and neurosensory abnormalities are the etiological factors. So, thus moving beyond a one-size-fits-all approach to a multimodal etiological driver-based strategy. For years, we classified dry eye as aqueous deficient or evaporative dry eye. Most patients have multiple overlapping mechanisms. Therefore, Deuce 3 proposed a driver-based classification, a new driver-based classification, including tear film component deficiencies, eyelid abnormalities, ocular surface abnormalities, and systemic drivers. The important take-home message from the updated definition is dry eye is a multifactorial disease. Symptoms include visual disturbance, and objective signs reflect the loss of homeostasis, and etiological-based classification is emphasized. So this Venn diagram shows dry eye is overlap of symptoms and signs. Always rule out other differences like allergy, infection. So pain without stain may indicate neuropathic pain or digital eye strain or early stage of preclinical dry eye disease where the homeostasis is lost but the physical damage is not yet visible. And the stain without pain, where the signs are more than symptoms, are more common in neurotrophic conditions. So, since both the signs and symptoms of the dry eye disease are heterogeneous, the differential diagnosis is very extensive and encompasses most ocular surface disease. This figure gives an overview of differential diagnosis of dry eye disease and their key differential features. So, DUCE 3 recommends OHPI-6 as the preferred screening questionnaire. It is a quick, practical, and highly reproducible, and it is suitable for busy clinics. A score of 4 or more indicates patient is symptomatic. The other validated symptom assessment questionnaire are Dry Eye Questionnaire 5 and Ocular Surface Dry Eye Index Questionnaire. So, once the symptoms are established, we need objective evidence of homeostasis loss. At least one of the following must be abnormal: tear film instability, noted by non-invasive breakup time less than 10 seconds, or hyperosmolarity, or presence of ocular surface staining, as mentioned here. So, symptoms plus loss of one of the three homeostasis marker equals the dry eye diagnosis. So, this is probably the most practical slide in the entire presentation. This slide mentions the sequence of testing. It should be from non-invasive to invasive. The order matters because invasive tests can alter the subsequent measurement. So starting with the ocular history, the history itself can give away the diagnosis. Many clues are obtained before touching the patient and slit lamp in the history. So we ask about the symptoms of dryness, redness, burning sensation, and their duration. History of emotional and reflex hearing are very important. as absence of them indicates severe dryness. We also ask about the contact lens wear, any past refractive procedure or exposure to chemicals or fumes, or history of conjunctivitis or viral infections that predispose the patient to dry eye disease, or any chronic long-term topical medication use. So moving on to the systemic history, this is where many diagnoses are missed, and the proper systemic history can help us to narrow our diagnosis. So we ask about the symptoms like dry mouth or small joint pain. So pertaining to diseases like rheumatoid arthritis or SLE, use of any chronic oral medications, uh, chemotherapy or radiotherapy to to the tumors, computer work more than 6 hours, history of any bone marrow transplant to rule out graft versus host disease, and any topical medications that can cause that predispose the patient to diabetes. The non-invasive diagnostic tools such as keratograph play an important role in the diagnosis and the management of diabetes. These investigations will be discussed in detail in a separate masterclass. So the DUCE-3 framework shifts our attention from disease classification to etiological driver identification. So our examination should focus on identifying these etiological drivers. So never jump directly to fluorescence staining. Always observe the patient externally. For example, presence of red papules or pustules on the nose are commonly seen in rosacea. The another overlooked eyelid abnormality is a floppy lid, which is characterized by excessive glass upper lid and easy eversion of the eyelid with minimal manipulation, thereby causing lid closure abnormalities, recurrent redness, and irritation. Most of these patients are commonly have associated sleep apnea for lid margin apposition changes like entropion, and eyelash deformations like trichiasis and dystrichiatic lashes. Check for deposits and crest along the lid margin to rule out blepharitis. Look at the meibomian gland orifices, the secretions, the nature of the secretions, presence of meibomian gaps or lipid saponifications along the lid margin, which are suggestive of meibomitis. Assess the punctal stiffness, its position, patency, opposition to the flow, and any evidence of any stenosis. Apply fluorescent strip and check for the tear film height along the lid margin with the help of cobalt blue filter. The tear film height can be measured with the help of a graticule attached to the eyepiece or by adjusting the height of the slit plane. In this image, in addition to the tear meniscus height, we can also demonstrate conjunctival calluses, which are seen as a loose, redundant conjunctival force. They interfere with the tear distribution and tear clearance, thereby causing symptoms in the patient. Then we measure the tear breakup time. Yellow filter is used for better visualization. So the tear breakup time is the first dry spot that appears after a blink. And when we check for the blink, look for the blinking rate as well as the completeness of the blink. Then we'll check the lid wiper region. Lid wiper region is a 2 mm subtarsal area which comes in contact with the ocular surface during blinking. So lid wiper epitheliopathy is the condition where staining and damage occurs to the marginal conjunctival epithelium of the upper eyelid. It results from inadequate lubrication and increased mechanical stress. Lid wiper epitheliopathy is associated with superior conjunctival calluses and MGD as shown in this picture. This lid viper epitheliopathy is more common in upper lid region. Interestingly, in this patient, we can see lower lid also is affected by lid viper epitheliopathy, which is a relative uncommon finding. Then we assess the conjunctival staining. In this clinical picture, grade 3 staining is appreciated in all quadrants. It's appreciated better with the help of Hello filter. We can grade the cornea staining based on the NEI scale or Oxford scale, where the cornea is divided into multiple segments and grade. Next comes the direct assessment of the tear secretion. Here, a simple visual assessment of the secretions from the lobe as well as appearance of the lobe can give us clues about the gland involvement in this dry eye disease. A dry 2% sodium fluorescence strip is touched onto the exposed palpebral lobe, and the tear secretion is visualized as a fluorescent washout area at the ductular opening. These examinations should not only help us to diagnose dry eye, but also direct us towards treatment decision. Thus, identifying specific drivers allows us to select targeted therapies. Covering management is beyond the scope of this masterclass and will be covered subsequent masterclass with case examples. Just to summarize, dry eye is a multifactorial disease with a loss of tear homeostasis. The examination should focus on identifying the key drivers of the dry eye disease, the tear deficiency, lid abnormalities, and outer surface inflammation. Thus, recognizing these contributors enables us for a personalized and targeted treatment approach. Thank you for your patient listening. Until next time, keep learning and keep digging deep into the surface.